that I helped put together with the help of other breast pathologists, Anna and Hala from Toronto, as well as colleagues in hematopathology and cytopathology. So I have to confess, I don't have a huge amount of experience in BIA ALCL cases, but I did learn a lot from working on this project. So I'm going to start with a case. The case we had was 58 years old at the time, and she had a past history of bilateral mastectomies for bilateral breast cancer, and then had immediate breast reconstruction with textured silicone implants. And then 9 years after her surgery, she noticed that her left breast was asymmetric and becoming larger. So she was referred to a plastic surgeon who ordered imaging. An MRI showed a left implant seroma. The surgeon did an aspirate of the seroma fluid and then did a bilateral capsulectomies and exchanged her textured implants for smooth devices. And on the requisition, he did note that he was concerned about BIA ALCL. This is an image from the cytopathology specimen. So we used liquid-based cytopathology for using thin prep, and then a cell block was made. The thin prep slide was very sparsely cellular, but there were scattered atypical large epithelioid cells with often multinucleation. The cell block was much more cellular, and at higher power, there were multiple atypical cells. Some of the cells had vacuolated cytoplasm. Many had bilobed or multilobed nuclei. Here's one with 3 lobes and multiple nucleoli, and mitotic figures were easily seen. So very atypical. This is an image from the contralateral breast capsule, which shows what we would normally expect from just a benign fibrous capsule around an implant. There's this
My video
fibrosis with patchy lymphocytic infiltrates. On the contralateral implant, though, there was a layer of fibrinous exudate on the surface, on the internal surface, and clusters of similar atypical epithelioid cells and mitotic figures in this fibrinous material. These cells showed strong membranous expression of CD30, as well positive expression of CD4, CD5, ALK is negative, and CD3 was aberrantly negative. So this was considered positive for CD30 positive anaplastic T-cell lymphoma, ALK negative. This slide shows the panel of IHC that was done at the time. She had some staging investigations which were negative. So her final stage was stage 1B. And this table outlines the TNM staging for BIA ALCL. T1 disease is when the lymphoma cells are confined to the luminal surface or just the seroma fluid. And with T2 and T3 disease, the lymphoma cells extend into the capsule to greater degrees. And then T4 disease is when the cells infiltrate beyond the fibrous capsule into adjacent tissues. Our patient had 3 cycles of CHOP chemotherapy and has had no recurrence and is considered in complete remission. So I'm going to stop for a question, and I think if we can answer, use the chat box, and Anna, maybe you can monitor this. My question is, patients with BIA ALCL typically present with, number 1, axillary lymphadenopathy, 2, unilateral breast enlargement more than a year after implant surgery, 3, unilateral breast enlargement less than a year after implant surgery, 4, bilateral breast enlargement, and 5, mammographic calcifications. So I can't see the chat box, Anna, but I don't know
I can
whether.
see that. So we have
Okay.
number 2 coming from most participants.
Excellent. Number 2. Yeah, number 2 is the right answer. So these are delayed seromas.
So we have only number 2s in the chat box.
Okay. So this diagram shows where the effusion occurs. This gray shaded area is the breast implant, and the pink area is the fibrous capsule, and the seroma forms between the capsule and the surface of the implant. Now, only about 10% in many studies of breast implant seromas are due to associated lymphoma. Most, I mean, there's other causes, including a subclinical infection, often bacterial, implant rupture, mechanical shearing, and the cytologic evaluation of the seroma fluid is really the gold standard to clarify the nature of the cause of the seroma. Flow cytometry without cytopathology is not recommended because there may be too few cellular events to interpret and also misinterpretation based on loss of T cell antigens. So it may not be clear based on limited cells with flow cytometry. So this disease was first described in 1997 and was adopted by the WHO in 2016 as a novel form of peripheral T cell lymphoma. Most patients present with a spontaneous unilateral capsule confined seroma. They may have pain or capsular contraction. They may be misdiagnosed as implant rupture. And the seroma usually develops 7 to 10 years after the implants were placed. So often delayed and almost always more than a year after the surgery. There's been, and the lymphoma is associated with textured surface implants. There's been no documented cases, to my knowledge, of BIA ALCL with smooth devices. Some patients will develop lymphadenopathy. Often this is reactive, but in some cases it can be involvement with lymphoma in the regional nodes. The average age of diagnosis is 50 years. This outlines the WHO classification of peripheral T-cell lymphomas that are CD30 positive, and it's the type 4 is the newly added BIA ALCL, which is ALK negative. This shows you the difference in appearance between the textured device, which has a rough texture rather like Velcro compared to the smooth surface devices. And these were developed because of improvement to the cosmesis of the implants, lower incidence of capsular contraction. They tend to stay in place and less silicone leakage with the textured devices. It's been hypothesized that this greater surface area of the textured devices favors bacterial biofilm growth along this complex surface. And then this leads to lymphocytic stimulation and subsequent T cell transformation, possibly some patients that might have genetic susceptibility with JAK1 STAT3 gene mutations. And as well, shedding of particles from the devices has been implicated in the development of seroma and lymphoma. 2 years ago, Health Canada suspended the big company that was licensed for texture devices in Canada. And then a few months later, the company Allergan had a worldwide recall of the BioCell devices. I couldn't find any updated information on the Health Canada websites, but the last information dates back to January 1st, 2019. And at that time, they had 26 confirmed cases of BIA ALCL with the Allergan's macro-textured implant and another 22 suspected cases. So a definite increase over the course of time. And Health Canada at the time estimated that 1 out of 3,500 women with this device would develop BIA ALCL. I've seen other reports that cite this rate to be a bit higher. So I'm going to pause for another question. Breast implant seroma fluid should be submitted entirely for flow cytometry, 2 discarded, 3 not sampled, 4 triage for cytopathology, flow cytometry, and culture and sensitivity.
So number 4 is coming, Penny.
Good. This is an easy one.
Yes.
Okay.
There's no room for wrong answer.
So for onto diagnosis, patients who are symptomatic should have breast imaging. Various modalities can be done. And if there's a peri-implant seroma, the fluid should be aspirated under ultrasound guidance. And if there's a mass, it should be biopsied and submitted for a lymphoma protocol. So for this seroma aspirate, the more fluid we get, the better, ideally 50 mils, if that can be obtained. And then it should be triaged first for cytopathology with formation of a cell block for potential IHC, then flow, and then to microbiology. Um, and again, most of the late seroma specimens are reactive, about 90%. And what we should look for are the large pleomorphic atypical lymphocytes. Uh, I'll show you some more pictures, but they're multinucleated, very atypical with prominent nucleoli. And in studies that have bigger series of this disease, usually in cytopathology, they're not rarely seen. They're often more than 70% of the cells in the seroma fluid. So they should be obvious. If there's fewer cells, then it may not be diagnostic, but it may be reason to repeat and continue to follow the patient. So I've listed some IHC that can be done. Usually we don't do a full panel on cell blocks, but you can demonstrate CD30 positive, ALK negative cells. Just remember that CD30 expression can be seen on a variety of benign cells, including activated lymphocytes and eosinophils. So it's not useful to do this as a screen. You really have to correlate with the cytopathology. And here's the picture, another picture here of what we see in a cell block specimen, the multilobated atypical cells. Also, the cytopathology is particularly important because in a number of patients, this is the only specimen in which we're going to see the lymphoma cells just in the seroma fluid, and you really can't find it along the capsular surface. And if that happens, then the stage is T1A. The surgical management for patients with suspected or established BIA-ALCL is en bloc surgical removal of the affected, with the affected implant being removed, and excision of the entire surrounding capsule, and removal of any breast masses or suspicious lymph nodes that might be involved. The removal of the contralateral implant is a bit more controversial. I think in our experience here, the plastic surgeons will remove them bilaterally. Okay, so for gross handling, if the specimen, the capsulectomy specimen comes to the lab fresh, you may want to contact the surgeon to see if there's any particular areas that are suspicious for lymphoma, and then handle them as per lymphoma protocol. If there's a fusion fluid in the fresh specimen, that can be aspirated with a syringe and then sent to cytopathology. The specimen should then be oriented. Hopefully there's sutures in place, and then pinned to a board and fixed overnight, and photographs can be taken at the same time. This diagram comes from a really good paper that has a proposal for handling breast capsulectomy specimens for patients with suspected anaplastic large cell lymphoma. And what they've done is recommended proper orientation with inking of designated margins and sampling at least 2 sections per side of the specimen. So here, this slide just outlines the grossing steps that we would do with any specimen. So generous sampling. For the capsulectomy specimens, you want to submit any fibrinous material on the luminal surface, any masses, and to submit the sections on edge so that the margins can be evaluated and the degree of infiltration, if it's present, into the capsule can be measured for staging of the disease. For capsulectomies for patients that are not suspicious of having anaplastic large cell lymphoma, some of the grossing steps are the same. I have to say, we never get intact capsulectomies. Often they're little tiny bits of fragment fibrous tissue, but we have started to submit these more generously and embed them on edge, just on the off chance we might pick up an unexpected case. In these cases that don't come oriented, we don't ink the surgical margins because we don't really know what's a margin. Question 3, how long should explanted breast prostheses be stored in the lab? 1, until the final surgical pathology report is verified. 2, 20 years. 3 months after the report is verified. 4, 5 years. 5, depends on storage space. Any answers, Anna?
No. Okay, so here is 4, 3 months, number 3 months, 3 months.
Okay. So I don't have a good answer for this question. There's really limited guidance for laboratory retention of the explanted breast prostheses. But what we suggested is that labs should develop their own policies based on local and provincial regulations. I did find one reference that recommended they be stored for 5 years, and that's what we do in our lab. Halifax sent out a survey last summer and asking this question amongst others regarding this topic. And most pathologists who responded, 67% said that they retained the devices for 3 months after case sign out. So I think as long as you have a policy, that it should be known, and the surgeon should know what the policy is as well. So on to surgical pathology. So much of the time, the capsulectomy specimens are from, if the patient has a seroma, is reactive. And what you may see are variable types of inflammatory cells. Often there's lots of vacuolated and multinucleated histiocytes. Look carefully on the inner surface for fibrinous exudate for the atypical lymphoid cells that you may see with anaplastic large cell lymphoma, and in which case IHC can help. Just be very careful to correlate this with correlate any IHC, especially CD30, with the cytopathology. In my experience, I've always taken these cases to the hematopathologist in my group for help, because they often have the best eye for the diagnosis of lymphoma. So for a case of BIA ALCL, our report should include the extent of tumor infiltration if it's present into the capsule or into the adjacent tissue, or if it's just confined to the inner surface of the capsule. And we should report the status of the inked capsular margin. This is a table showing the IHC panel that you can apply for suspicious or definite cases. And the lymphoma cells express CD30 and MUM1 strongly. ALK is negative, and the T cell markers are sometimes negative or diminished. So we're aberrant expression of some T cell markers. If there's a specimen submitted for genetic studies, often clonal rearrangement of T cell receptor genes can be demonstrated. ALK gene rearrangements are negative, and other studies for other forms of ALCL are negative. For lymph nodes, with lymph node involvement, the patterns can be variable with this type of lymphoma. Often it's sinusoidal and it can be focal, and this is why a core biopsy or FNA may not be very useful in this setting. There's other patterns of involvement: perifollicular, interfollicular, diffuse, and Hodgkin-like pattern. And the misinterpretation as Hodgkin's lymphoma can be a pitfall. And there's a greater risk of lymph node involvement if the lymphoma from the seroma has extended beyond the fibrous capsule. If following treatment for surgery for BIA ALCL, patients may be given chemotherapy, and the protocols are for the same as ALK negative systemic ALCL, and there's been no established benefit for radiotherapy. For patients who have localized disease, so T1 disease, the 5-year survival rate is 100%. So these patients have a complete remission, so excellent survival. When it extends beyond the capsule, the mean overall survival is only 12 years. And it's been extrapolated because of this information that early diagnosis does impact outcomes. So patients who are symptomatic should be worked up. With established cases, there are 2 agencies who should be notified. In Canada, we should report the case numbers to Health Canada, and the plastic surgeons also have another registry called Profile, located in the States, that does have a Canadian data subset. So they should report the cases to this agency as well for tracking. So in conclusions, BIA ALCL accounts for about 10% of late peri-implant seromas. Plastic surgeons and patients have been alerted to this disease, and so we have been seeing a lot more specimens, both in cytopathology and patients having their implants removed with capsulectomies. So for seroma fluid, as much fluid as possible is best. Triage first to cytopathology with a cell block, then flow, then to micro. And I find it's helpful to seek assistance with my hematopathology colleagues. And for grossing, adhere to a standardized grossing protocol with mapping for the capsulectomy specimens. So I just have some references. So I think we can stop for questions and discussion.
Thank you, Penny. That was really a great and comprehensive presentation. If you have any questions, please type your question in the chat box or raise your hand and we'll let you speak as well. I don't see questions at the moment, Penny. I know you will be presenting a case, so we'll allow people to collect their questions. And before you will be presenting your case, we'll ask you whatever is available, unless anyone has raised hand, I don't see. Okay. Oh, questions are coming, Penny.
Okay, let's do it.
How often would you going back to the specimen result in a different diagnosis? Or is it more for the legal reasons?
Yes, I don't really know. Going back to submit more tissue, you mean?
Yes. Mm-hmm.
I think I guess just for peace of mind and sampling these thoroughly, we've changed our protocol and are going back to submit more sections. And I suppose for legal reasons is also in mind as well. I haven't had any cases where I've gone back and found anything different, having said that.
Okay. Excellent presentation. So people asking if you can send grossing protocol.
Yes, we can do that.
Okay, so maybe you will send it to me and I will share it with the participants. Another question, would you show all capsules to a hematopathologist or just suspicious ones?
Just the suspicious ones. I feel pretty comfortable in handling the ones without any atypical cells in them.
Okay, another question, what do you find in culture and sensitivity?
So that's variable. There's different types of bacteria that can be found. I mean, I think sometimes people have subclinical infection and nothing grows on CNS, but a whole spectrum of gram-positive and gram-negative bacteria can be associated with seromas.
Okay, Penny, I think we'll stop for questions now because we have to proceed further. And I'll let Nicolina to step in and introduce next speaker.
Hi, everyone. Next speaker is Dr. Sharon Moses from Sunnybrook Hospital, and she will present the case. Sharon?
Yes, I'm just trying to share my screen. Can you see it?
Anna?
Do you see my screen? You definitely not, and maybe not even. Can you hear me?
We can hear you and we can see your wonderful picture.
Oh, you do? Okay, sorry.
Looking into microscope.
Okay, so let me just
here.
make sure. Yeah, you see my screen now, right?
Yeah.
Okay, so I would like to share with you a case. Just 1 second. I just need to make sure that I'm in the right, right slide. So I want to share with you a case of a unusual tumor. The patient was 76 and she underwent mastectomy and sentinel lymph node biopsy for a multifocal tumor that had one large tumor, 7.5 centimeter, another one 2 cm, and a couple of few millimeters of invasion. And the patient had lymphovascular invasion, and one of the lymph node was positive for metastatic carcinoma. On scanning magnification, we can see easily the infiltrative pattern of growth And also there is some sort of a mucin or a matrix that has to be clarified a little bit better on higher power. And on higher power, really, we see areas where we have extracellular mucin and cohesive groups of cells that have this intracytoplasmic lumen that has this targetoid morphology. And in other areas, we can see that, in fact, we have a single cell files with very nice signet ring cells. And there is also a little bit of extracellular mucin in these areas as well. Other areas shows this extra those neoplastic cells that are definitely signet ring cells floating as single cells, not the cohesive pattern that we saw before in that extracellular mucin. The tumor was positive for GATA3 in both the single cell files and the clusters floating in extracellular mucin, and mammoglobin was negative. Ecadherin was negative in all these areas as well. The tumor was positive for ER and PR and was negative for HER2 by immunohistochemistry. To summarize, we have a tumor that is a nice example of invasive lobular carcinoma with extracellular mucin and signet ring cells in an elderly patient with multifocal tumor, positive LVI, positive lymph node. The patient also had areas of LCIS. So this tumor is an uncommon pattern of invasive breast carcinoma in the new or fairly new 5th edition of the WHO book, is classified as a new entity, and it is unknown, it states that it's unknown whether these tumors are subtype of mucinous carcinoma or invasive lobular carcinoma. They are frequently present as palpable mass. They're more likely to be of a higher grade 2 or 3, and could be HER2 positive compared to classic lobular carcinoma. And approximately 30 cases of invasive lobular carcinoma with extracellular mucin have been reported so far in the literature. The lobular features are areas of linear or single file infiltration, intracytoplasmic lumen or signet ring cell morphology, pseudoglandular and pseudocribriform architecture, and even solid growth may be seen in these cases. It may or may not have accompanied LCIS. If you have it, is certainly a clue. Ecadherin is negative, and so is the altered localization of beta-catenin as well as P120 if these are available. Unlike mucinous carcinomas, neuroendocrine features are usually absent, and on a molecular level, there is copy number variation in 1q, 16q, and FOXA1, as well as mutations in PI3 kinase. In 8 cases, when it was examined, there was a frame shift or deleterious mutations in CDH1 gene. The mucinous features that we see are obviously the extracellular mucin, as well as positive stains for MAC1, MAC2, and MAC6. The differential diagnosis is obviously mucinous carcinoma, matrix producing metaplastic carcinoma, but one should be just careful not to mix up chondroid or pseudochondroid and mucinous material, as well as metastatic non-mammary carcinoma. So I suggested to Nicolina that we will present this case just to increase the awareness of this entity, which is recently added as a variant of invasive lobular carcinoma in the Blue Book. And so that people will keep in mind when they consider site of origin and metastatic site, because this is not the way most of us will envision in our brain how invasive lobular carcinoma would look like. And these are some of the references that describe the small series that are described so far in the literature. That's it.
Thank you, Sharon.
I will stop sharing. Okay.
Our next case going to be presented by Dr. Penny Barnes. Penny, can you try
Yes.
to share your screen?
I shall try to do that. Okay. All right. Can you see it now?
Yes, we can see it.
Yes.
Okay. Let me just try to put it full. So technically challenged. Here we are. Okay. So I had an interesting case a couple of weeks ago, or almost a month ago. The patient was 69 years old, and she had a suspicious mass identified on breast imaging. A core biopsy was reported as benign, but then she went on to have a wire localization excision and sentinel lymph node biopsy. And the gross report that came with the case in consultation described a 2 centimeter circumscribed mass, and the entire specimen was submitted. This is what I'm going to show. I've got a lot of pictures because it looked quite variable, but this is one section where the low power view looked rather like a sclerotic papilloma. I apologize for the defect in this section. At higher power, you can see that there's some necrosis, and there seems to be 2 types of cells, kind of darker staining cells forming tubules, and then a proliferation of larger cells with lighter staining cytoplasm. These lighter cells are P63 positive, so a proliferation of myoepithelial cells within this lesion. And these cells at higher power look cytologically atypical, and there were quite a few mitotic figures. I don't know if you can see them here. There's one at the end of my arrow. So here's another view where it looks rather lobulated and circumscribed, but kind of variable in appearance. I have a higher power picture of this area, which this is a smooth muscle myosin heavy chain showing a dual cell layer throughout some of this more lobulated area of the tumor. And then off to the right, there's absence of a myoepithelial layer around more infiltrative ductal structures. This was the opposite side of this transected tumor. And I have 3 little areas that I wanted to show you around the edge. In this area, we have almost a papilloma-like area, but then some infiltrative nests around desmoplastic stroma and an area of papillary ductal carcinoma in situ. At the bottom of this particular section, there's infiltrative, almost squamoid looking tumor with necrosis. Here's more of it here, where there's almost dyskeratotic cells seen here. This is the smooth muscle myosin heavy chain, which shows absence of a peripheral layer. And there's preservation in this area of papillary DCIS. This area, the tumor was strongly CK5-6 positive, and there's the associated intermediate grade DCIS. And this is another part of the tumor showing more infiltrative growth. At higher power, the cytology was quite pleomorphic. There was no myoepithelial component. And here's some more of the atypical cells that look rather squamoid. So this is a biphasic malignant neoplasm, and we favored a malignant adenomyoepithelioma with associated metaplastic breast carcinoma with mostly squamous features arising in the adenomyoepithelioma. It's Nottingham grade 3. The lesion overall was 20 millimeters. The tumor was triple negative with associated DCIS. 2 sentinel nodes were negative for metastasis. So adenomyoepithelioma is a biphasic neoplasm, and usually these are benign or have low malignant potential with small epithelial-lined ductal spaces, luminal ductal cells with a proliferation of variably enlarged myoepithelial cells. The differential diagnosis is a simple papilloma and pleomorphic adenoma. The WHO, the most recent blue book, classifies these as adenomyoepithelioma and adenomyoepithelioma malignant. There's a recent publication in Histopathology that has a proposed more complicated classification, and they suggest that in addition to adenomyoepithelioma, that there is an atypical form where you see necrosis, mild to moderate nuclear atypia, more than 3 mitoses per 10 high power fields, and no infiltrative growth. And then malignant adenomyoepithelioma in situ, so a pattern of DCIS within this neoplasm, and then an invasive counterpart, which is essentially epithelial myoepithelial carcinoma. And then as this case shows, adenomyoepithelioma with invasive carcinoma. So I guess we'll see whether this particular classification is adopted in the next iteration of the WHO. For malignant adenomyoepithelioma, there's not a lot of data because it's quite a rare tumor, but it's reportedly affects elderly women most commonly. Some patients have a long-standing mass, which then with recent growth. The carcinomatous component has a wide spectrum of appearances. It may show features of invasive breast carcinoma, no special type, or special types including lobular carcinoma, but not uncommonly the invasive component is a type of metaplastic carcinoma, frequently triple negative. The prognosis depends on the features of the invasive subtype, and metastasis can occur several years after the primary diagnosis. Typically, hematogenous spread, lymph node disease is rare. So, and there are some references. I don't know if anyone else has seen a case like this.
Thank you, Penny. Very interesting case. Any questions in the chat? Anna?
I just had a case this week of a malignant adenomyoepithelioma coming from another province, but did not have a malignant, an additional carcinoma NST or metaplastic component. But this is so rare, so it's nice to see 2 of them in one week.
You'll have to show yours the next time.
Yeah, I should. I actually showed it to one of my colleagues, and she asked me if I'm going to show it today, and I said no, it's too early. I just saw it last week at the end of the week, and yeah, we'll show it next time.
Very much great presentations.
Yeah.
Our next presenter is Dr. Sylvia Papp from Peterborough Hospital. Sylvia, could you please share your screen?
Nicolina, maybe we can proceed with the next case while Sylvia is trying to figure out what's going on.
Can you hear me now?
Yes.
Okay, perfect. I'm so sorry about that. I never have microphone issues. That's so funny.
Okay.
Of course, it happens today. All right. I will reshare my screen.
Now we can see you. Yes.
It's a good thing I had people helping me. All right. So now can you hear and see my screen?
Yes.
Okay,
No
perfect.
problem.
All right, so I have a case of a 39-year-old woman who I looked at her both lumpectomies actually, but this is her first lumpectomy. So in terms of her general just background, she was a healthy 39-year-old who has one previous child, and she was only taking a herbal supplement. Only previous pathology I found was just some products of conception from a 2016 missed abortion. And she came in for a palpable breast lump near her right nipple, which she discovered herself. And on imaging, imaging showed a dense, round 1.6 centimeter mass with smooth margins. The radiologist favored a fibroadenoma. Her core biopsy revealed a cellular fibroepithelial lesion, and it was that time favored to be a Phyllodes tumor by one of our pathologists. So I received her lumpectomy, which we found the lesion and submitted it in toto, and it turned out to be a 2.6 centimeter lesion. So I'm sure you've all seen this chart before of Phyllodes. So her tumor was Phyllodes. I will show it to you. So, you know, the benign, borderline, and malignant categories, you know, based on mitotic activity, stromal cellularity, stromal cell atypia, margins, whether or not the stroma has overgrown, and the presence or absence of heterologous elements, and importantly, if there are malignant heterologous elements. So this is what her lesion looked like. It was, as you can see, it was relatively well circumscribed, mostly. So it had these, you know, large leaf-like structures within these dilated cystic spaces. And you can see, even just on this low power, that the stroma was quite heterogeneous in terms of cellularity, ranging from mild to moderate to high cellularity. Here's another portion of that. So there was, in her particular case, there was no stromal overgrowth. However, there were areas of stromal expansion that did not meet the criteria for stromal overgrowth. This is another view. So it was a very heterogeneous lesion, as you can see. And so while the borders of this lesion were, they were more lobular, there was no areas at all where we could see definitive infiltrative or permeative growth. It was mostly these peripheral nodules, as you can see here. And then this, her superior margin ended up being positive. In terms of stromal cell atypia, it also ranged from completely benign to areas like this, where it would be moderately atypical, to areas like this, which were markedly atypical. You can see these large pleomorphic cells. So in the end, Dr. Mulligan, thank you so much for looking at it in consultation with me. It was decided that there was marked cellular atypia in the stroma. And the mitotic activity was what struck me about this case. It was highly mitotically active. You can see I've circled just a few mitotic figures. And so consistently, if you went throughout these more cellular stromal areas, mitotic activity was consistently 10, like greater than 10 mitoses per 10 high power field. And in maximal concentration, they were 27 per 10 high power field. So I was having difficulty grading this Phyllodes, so I sent it to Dr. Mulligan, who kindly looked at it for me, because so it had features of both borderline and malignant. So it was largely well defined. There were some peripheral nodules, but it wasn't so infiltrative. There was no stromal overgrowth, just stromal expansion. There were no heterologous elements in this case. The stromal cell atypia and the cellularity at the peak end was actually marked for both. And as we said, the mitoses were quite abundant, much greater than 10 per 10 high power fields. So some parameters that weren't, so in some reading I have done, and there was a very nice paper from Dr. Slodkowska, who I see is also on the call today. Her and her colleagues wrote a paper in Modern Pathology in 2018, Fibroepithelial Lesions of the Breast, a comprehensive morphological and outcome analysis of a large series, in which they showed that alone, some of these things such as unequivocal tumor necrosis, extensive stromal overgrowth that it equals at least a 2 by 2 square centimeter area of pure stroma, a malignant heterologous element, and possibly a mitotic count that's greater than 25 per 10 high power fields. If you saw any of these alone, may warrant a classification of malignancy on its own. So just to summarize, I sent it out as at least borderline phyllodes, can't exclude malignant. And Dr. Mulligan, I really liked the way she brought them two together and summarized as a high end of borderline, low end of malignant phyllodes tumor, and obviously recommended excision with clear margins. So the surgeon did have to go back because there was a positive margin. It was re-excised. The margins were less than 1 centimeter. So the radiation oncologist is wondering, she needs another re-excision before radiation can be considered, because it was under a centimeter, but I think over 5 millimeters. I have also sent that off to Dr. Mulligan because I was struggling with the margins of the re-excision. So just some points for discussion. I wanted to discuss how the people here felt about this high mitotic rate on its own. Do you think it could warrant a classification of malignancy? As well, I know that some centers practice margin clearance of 0.5 centimeter instead of 1 centimeter for borderline or malignant phyllodes tumors. And also on a core biopsy, I'm curious to know in a pre and a postmenopausal patient, how you would handle a diagnosis of a cellular fibroepithelial lesion. And thank you so much.
Thanks, Sylvia. I thought I recognized it, so thanks for sharing it. So yeah, this was a real struggle for me. As you went through the table very nicely. Sorry, that's just Siri interrupting me there. Sorry about that. So sorry about that. So as you went through the list of features, I thought there was focal hypercellularity, but it wasn't diffuse, which is one thing, and then very focal and marked atypia. So it really was the mitotic counts that were standing out in this lesion, separate from all the other features. And I think probably the counts are at least 25 in more than one location. I can't remember exactly, but they really were very prominent and easy to get high numbers. I think our hands are tied, because in the 5th edition of the WHO book, they're fairly definitive in saying that you need all those features to push it into a malignant category. But when we hear Dr. Tan talk about phyllodes tumors, she'll say, well, maybe if I don't have all the features, but it has this and this and this and this, I'll put it into the malignant category. Okay, I'm going to take off my watch at this point. So I did actually share it with one of my colleagues, and they would have put this into a malignant category. But I just wasn't too comfortable with putting it definitively in the malignant category, given that it lacked most of the features, I guess, for malignancy. So I tend to go back to Azbieta's paper and her colleagues, which is a really lovely paper. And we've had more than one case of this where the mitosis really are out of sync with the rest of what's going on in the lesion. And for that reason, and I think I probably reached out to Azbieta, asking what does she do with these? I put in that sort of borderline, between borderline and malignant. I suppose one of the reasons I like to hold back from calling it definitive malignant is because, she may well go on to have radiation if you call it definitively malignant. I think basically, even though, in the paper, that feature was sufficient to assign it to malignant category, I'm not sure we have data on those lesions where the mitotic count is the outlier. But Azbieta, you can correct me if I'm wrong there. So I don't know what the metastatic potential of these rare lesions is.
I absolutely.
Is Azbieta on the line?
Yes. Can you hear me?
Yeah.
So I agree 100%. In our paper, it was true that none of the borderline had more than 23 mitosis, but we put a disclaimer that more work is required to verify this. And these fibroepithelial lesions, as probably every single one of us on the call knows, they are so heterogeneous, they just don't follow any rules. And this is just one like that is exception to the rules.
It's kind of the one you wonder if, you know, this hadn't been excised for maybe 6 months, then we would have been seeing stromal overgrowth and an infiltrative growth pattern. But, you know, we catch these earlier because of imaging perhaps, and they're excised at an earlier date. So hard to know.
Anna Marie, do you want to comment on margin clearance as well, if you don't mind?
Yeah. I mean, the 1 centimeter is arbitrary from what I know. So our surgeons typically in this setting would look for at least 1 centimeter. I mean, 0.5 is it's very narrow in these cases, especially, I mean, in this case, there were these small nodules around the periphery. So she could easily have residual nodules that is being missed. So I guess the more, the better, but we don't have a clear definition of what is a safe margin. And, you know, there's some studies, especially with, I think, the benign end of these, where, you know, margin is not necessarily predictive of recurrence, with recurrence not happening when there's positive margins, but negative margins and you still see recurrence. So it's not a clear-cut relationship.
Thank you very much. Great comments.
Thank you so much.
And just in terms of the core biopsy, Sylvia, you know, for these, if I see mildly hypercellular stroma on a core, but none of the other features that would make me be concerned about phyllodes, I'll call it a fibroepithelial lesion with mildly hypercellular stroma and say that I favor fibroadenoma. They are going to be followed. The patients will be followed for a bit. If I see, though, more features other than hypercellularity, such as a few mitoses, you know, more marked hypercellularity, or any other features that may, you know, be indicative of a phyllodes, then I'll give the differential of a cellular fibroadenoma and the phyllodes, and that it should be excised. But most of them probably fall into the former category where they're more likely a cellular fibroadenoma and they can be watched. And if the lesion grows at that point, they can be excised. That would be my approach.
And what about like the pre and postmenopausal setting? Would that make a difference at all in terms of a cellular fibroadenoma versus more favoring a phyllodes later on?
Yeah, I mean, age I think is important. I mean, cellular fibroadenomas are typically in the younger age group. So once I'm seeing them, you know, older individuals towards, you know, their 40s or later, a cellularity would be more of a concern for me. So I might be less brave and just leave it with the differential.
That's great. Thank you so much.
And I look forward to seeing the re-excision.
I've already sent it. You should have it.
It may not have gone to me, but that's okay. I'll look out for it.
Okay, thanks.
Thanks, Sylvia.
Thank you, everyone. So this is great introduction for our next presentation. Next presenter is Dr. Amir Samani from Humber River Hospital in Toronto. Amir, can you try to share your screen?
Hello.
Hi, Amir, we can hear
Hi.
you.
So you have my screen now? Is it there?
Yes.
Okay. Let me go to a slide show. All right. I don't know why it shows like this, but anyway. Okay, I'm presenting a survey report on counting of mitotic figures in phyllodes tumor. The background is the mitotic count is one of the criteria for grading phyllodes tumor and probably the least subjective ones. I used to use hotspot to count mitotic figures. However, one of my cases was reviewed by one of the breast pathologists who is an author of a breast pathology book. And at that time, I found that she disagreed with me in using the hotspot. And she reported differently the number of the mitotic figures in that case. So I was actually puzzled with this review of my case. I did a quick search in the internet and I found that actually even recently in 2017, for example, this paper published from our colleagues in McMaster University in Hamilton, they still think that, you know, there are some school of thought thinking that we should not use the hotspot and it may actually bias us for the grading of the tumor. So I thought that it's not a bad idea to design a survey and ask breast pathologists in North America, Canada, and States to see what is the consensus. So my questionnaire was very simple. I said some pathologists find a hotspot and start counting mitotic figures in 10 high power field from that point. And others believe that this may be misleading and they count several random foci and report the average of mitotic counts. And at the end, I asked, what is your opinion? I had the 10 breast pathologists responded me, all of them, and then some of them from Canada. I read some of those response for you, replied for you. For example, from Toronto, one of the breast pathologist wrote me, as my teacher, Peter Rosen, used to note, if you want to improperly inflate a stromal cell mitotic count in a phyllodes tumor, stay close to the epithelial component. I believe it is important to evaluate multiple high power field in multiple blocks. So basically, this was against using hotspot. From Hamilton, I do a mitotic count in 10 high power fields on every slide. I then report a mitotic count saying from this number up to maximum value, particularly in cases where it can be heterogeneous. So not a single average number, but almost on every kind of, every slide, and then give a average number. From Montreal, one of the pathologists said grading should be based on the worst area, meaning hotspot, and mentioned that in Brigham and Women's Hospital also they do that. They use the hotspot for mitotic count. One of the breast pathologists from Beth Israel said, actually not using hotspot, but using the whole tumor overall for mitotic activity, meaning an average. MD Anderson, hotspot, Yale University, again said hotspot, but unfortunately not all papers specify the best approach for counting mitotic figures. So the statistics showed that 60% of breast pathologists in this survey use hotspot for mitotic count in phyllodes tumor, whereas 40% use the average, not hotspot. Interestingly, the consensus review on phyllodes tumor published in 2016 in histopathology didn't mention at all any rule or recommendation for how to approach this problem in the phyllodes tumor. In 2018, our colleagues from Sunnybrook, including Sharon, they published this comprehensive morphological and outcome analysis of a large series in fibroepithelial lesion, and they recommended to use 10 consecutive high power field in hotspot. And they mentioned the size of field diameter, dedication put into the finding of the most mitotically active area, and the method one uses to select those 10 consecutive fields once in the proper area may differ. Historically, in this mitotic count, using mitotic count as part of the grading in phyllodes tumor, you get back to a paper published in Cancer in 1978, Cystosarcoma phyllodes, a clinical pathological analysis of 42 cases. So in that paper, which counted as the kind of mother of the this kind of grading, they used my number of mitotic figures in 10 high power field as was evaluated in the Philodes tumor, and they used the greatest mitotic activity, meaning that they used the hotspot. And the microscope they used was A0 microstar microscope, and with 40x high dry objective, 10x wide field eyepieces. This is one of the microscopes used in that paper. And as you know, many of us these days use kind of a new wider area of field of area, Nikon or Leica microscope. And compared to that one, which used in that 1978 paper, our field of surface is much higher, bigger, and the field of diameter is much bigger. So if we compare our current microscope to those used in 1978, basically we have to use 7 fields of high power fields instead of 10. In most recent WHO breast tumor classification, in the Philodes malignant Philodes tumor criteria, it is recommended to use more equal or more than 10 mitosis per 10 high power field. And it is mentioned that the high power field is a field of 0.5 millimeter of diameter with 0.2 millimeter square of area. But even in this issue, there is no discussion about using the hotspot or not. And this kind of recommendation from WHO, although it's a consensus and it's good to have some kind of consensus, there are 2 issues. Number one is this kind of recommendation is not evidence-based. As I said in the previous slide, if we want to use the 1978 grading paper, we need to use 7 field, high power field instead of 10. But what is recommended by WHO, I didn't find an evidence-based study for this 10 high power field in the new microscopes. And second problem is we have at least 9 different categories in this field of area. And this is, for example, from the CAP synoptic report, as all of us uses on a daily basis, to report on grading of the invasive carcinoma. And you can see that 9 categories of 9 different microscopes, all of them with field of diameter of 0.5 and area of 0.2, but they have different, they give different scoring. So as I said, this recommendation from WHO, although it's good to have some recommendation, but it's not yet perfect. And interestingly, report from recent report, 2020 in archive, they use the digital pathology to approach for the Philodes tumor and counting the mitosis. So they use the times 40 objective high power field. In their system, the high power field is 0.084 millimeter square. And what they found was both whole slide counting of mitosis and 10 high power fields, meaning average or just 10 high power field, had similar statistically significant correlation coefficient with grade, stromal atypia, and stromal hypercellularity. It shows that evidence-based study still is needed in this area. And the conclusion is, as I said, there is a need for evidence-based consensus on using or not using hotspot in Philodes tumor. And new studies are needed to consider the field of surface in reporting the mitotic count. Thank you.
Thank you, Amir.
Welcome.
So any comments from the audience?
I just want to say, Elizbieta, I think that our group also looked at, we compared for one of the USCAP presentations 2 ways to count mitosis. Was that a star shape versus like a typewriter, or was that hotspot versus a average?
So we always use hotspot. It's just
Yes.
there's even
Yeah.
differences how to
Yeah.
count in a hotspot.
Yeah.
Yes,
Right.
yes, that was true.
I just want to say that this is a good thing to bring up, but I think that philosophically one can argue that the biological behavior is dictated by the worst area in most tumors. So with this principle in mind, it makes sense to look at the hotspots rather than the average, because I think that from my practice, there are cases that are highly heterogeneous. And if you just average, you may underestimate the amount of mitotic fingers. But at the end of the day, it's a very difficult claim to come up with solid evidence, because you actually need to use patient outcome as the way to determine where to count, and not a survey, in my opinion. But thank you for bringing it up.
You're welcome.
Yeah, that's really interesting data. I'm surprised actually so many average.
Yeah.
I've always gone with hotspots. And I tend to I find the most mitotically active. In phylloides, I have to say I do a lot of mitotic counting. I count multiple fields on every slide. I usually give a range and then give the highest. So I'm surprised to see that 40% are averaging. Just a comment in general about mitoses. You know, I don't know if we're seeing more now than previously, and I don't know if that's related to better fixation. I mean, we fix rather rapidly after excision, so we're catching the cells in mitoses, because, you know, reading, I mean, it's rare now, other than hyalinized fibroadenomas, I'd say that I see a fibroadenoma that doesn't have 1 or 2 mitotic figures. So I think we're definitely either spending more time counting them, or, you know, we're seeing more in the sections because of better fixation. But on the hotspot issue, I would go with hotspot for sure. But as Sharon said, we do need outcome data, and it, you know, it does go back to Sylvia's case. You know, 1 feature alone, is it enough? And we do need outcome data to see how those rare lesions that, you know, have high mitotic counts, but without the other features, how they behave.
Thank you, everyone. Our next presenter is Dr. Anita Bain from Cambridge Hospital. Anita, could you try to share your screen?
Sure.
Yeah, we can hear you. And we
can you hear me?
Yes, and we can see you.
Great, great. Good afternoon, everyone. It's lovely to see you all virtually and see that everyone is doing well. And thank you to Anna and Nicolina for inviting me to participate. So I have what I thought was an interesting case to share with everybody, moving away from the spectrum of phylloides tumor, but into an area that has undergone a little bit of reclassification with the 5th edition of the WHO breast tumor classification. So let me see if I can advance this. So my case is that of a 54-year-old female. This was a consult case, so just to let you know, I've only retained 1 H&E slide. But the lady had a cystic lesion identified radiologically in her right breast, and she underwent a diagnostic core needle biopsy, which I didn't see, and it was diagnosed as atypical ductal hyperplasia, cannot exclude DCIS. She subsequently underwent mastectomy and central lymph node biopsy. And I think a mastectomy was chosen because this was centrally located within the breast. So the on gross description, a solitary lesion was identified centrally in the breast. Maximally, it measured 32 millimeters in diameter, and it was described as well circumscribed with possible areas of central necrosis. And so this is a low power scanning microscopy section. Apologies again for the artifact in the center, but I think this view does illustrate a couple of things. One is we have this solitary lesion, which appears to have this fibrous capsule, for want of a better term, that separates it from the surrounding breast parenchyma, which looks unremarkable. And I can think even at this magnification, we can all identify that this has a papillary architecture. On slightly higher power view, you can see the fibrovascular fronds, which are proliferating within the center of the lesion, and then this marked circumscription at the edge. Slightly higher power view, you can appreciate the thin capillaries of the fibrovascular core. And I think one thing that stood out to me at this magnification was the prominent lymphoplasmacytic infiltrate both within the fibrovascular cores, but also at the lesion breast stroma interface. And then even more striking at higher power was the marked nuclear cytologic atypia and the prominent and frequently abnormal mitotic figures that were seen in this case. So while I don't have the studies to show you, a number of ancillary studies were conducted, including a panel of myoepithelial markers, all of which were negative both within the fibrovascular fronds and at the edge of the lesion. The lesion was strongly and diffusely GATA3 positive. It was ER and PR negative, HER2 new strongly 3+ positive in greater than 90% of the cells. There was surprisingly focal TTF1 positivity, but thyroglobulin was negative, napsin A was negative, and then a panel of other immunohistochemical markers were all negative. So my diagnosis in this case was actually of an invasive carcinoma, but with obviously a comment saying that this had the architectural features of an encapsulated papillary carcinoma, but had high-grade cytologic features and a worrisome biomarker profile. And as per the WHO 2019 new recommendations, this was to be considered, staged and managed as per an invasive breast carcinoma. I did also, because this was a consult case, contact the original pathologist and make a comment that despite the immunohistochemical profile being supportive of a breast primary, both clinical and radiological exclusion of a metastatic papillary carcinoma would be prudent in this circumstance. So just a quick word on how this encapsulated papillary carcinoma with high-grade cytologic features has been reclassified using the 5th edition of the WHO Blue Book. And they cite lesions presenting with a growth pattern similar to that of an encapsulated papillary carcinoma with nuclear pleomorphism and increased mitotic activity and or triple negative or HER2 positive phenotype should be graded, staged, and managed as per invasive breast carcinomas. And subsequent to that quote, they cite 2 papers, one by the Nottingham group, Rathka et al., and the second by a Chinese group, Liu et al. The latter I could only access in abstract form, but the former I was able to download and review the paper, and I'm happy to share that with anybody if they would like it. But I thought it would be valuable, perhaps, in light of this case, to go through that paper. So in the histopathology paper by Rathka et al., they have 12 cases of encapsulated papillary carcinoma, high grade. The median age of their patients was 58 years, but the range was quite varied from 34 to 80 years. The median tumor size was 27 millimeters, but again, range from 10 to 80 millimeters. All of the described lesions were solitary, all had high-grade nuclear features, and all had high mitotic counts with a median of 22 mitoses per 10 high-power fields. If one were to use the Nottingham grading system, they would have been given 3 for tubules, 3 for nuclei, and then either a 2 or 3 for mitoses. None of the lesions that were in this paper had myoepithelium demonstrable either within the fibrovascular cores or at the stromal interface, and 68% of them had a triple negative phenotype. 4 were ER/PR positive, and 1 was ER positive, ER positive, ER negative. And 11 of the lesions, actually that should be HER2 negative, my apologies, and then they didn't have a HER2 result in the 12th case. 2 and 4 cases respectively were positive for high molecular weight cytokeratin 5, 6 and or EGFR. And in follow-up, although they did provide the caveat that their follow-up overall was quite short, something like 28 months, 1 in 10 patients died of metastatic disease. So I thought this was the first time that I could concretely make the diagnosis of encapsulated papillary carcinoma high grade, and I thought I would share it with the community. Happy to answer any questions.
Thank you, Anita. Great presentation. Really important to be aware of that and to look closely to cytology in these papillary lesions. Any comments or questions from the audience?
We have a question here. What synoptic report did you use for the case?
I used the synoptic report for invasive carcinoma. Then under subtype, I put other and said encapsulated papillary carcinoma high grade. Please see comment, and in the comment, I made the reference that these are now considered as per the 2019 guidelines to be an invasive breast carcinoma, and et cetera, et cetera.
Anita, I also find that classification based on the Nottingham paper a little bit confusing. So should we call EPC then low-grade EPC if it's a high-grade? Or should we not even use that terminology and call them invasive and maybe in the comments say this is what it is?
Yeah, I think this adds another layer of complexity to what is already a very difficult area. And obviously we have Anna Marie on the line, who's our world expert. For us, determining what the lesion is and then ensuring that our clinical colleagues understand the implications of that. So my practice is as per the WHO, if it's grade 1 or 2, I put it on the DCIS synoptic and I put the comment saying that these, while some people regard these as an indolent form of invasive carcinoma, it's recommended that we stage and manage them as per DCIS. And then conversely, when I had the high-grade lesion, put it on the correct synoptic and then put the qualifier comment.
Would you say it's the first one, would you say a low-grade EPC?
I don't think I would. I don't think that has not been my practice so far, but I'm interested to see what other people say. Yeah.
I see Anna Marie is willing to comment.
Anita's embarrassed me into having to comment on this. But you know, I had a case just like this that was HER2 positive. I guess because you saw it in consultation, you don't know if the patient was treated with neoadjuvant or not neoadjuvant, sorry, anti-HER2 therapy. I'm assuming she was.
I'm hoping she was, Anna Marie, but I didn't get follow-up. Yeah.
Right. So I guess, you know, this is another one of those entities where we don't have a lot of clinical data on how they behave because they're so, you know, they're not obviously not infiltrative. They have that circumscribed pushing edge. Do we know if they behave as aggressively as their, you know, infiltrative triple negative or HER2 positive counterparts? They may not. The data we have, as Anita showed, is really very limited and very short in terms of follow-up. So I think we need a lot of probably multi-institutional studies to look at this, and we may never have enough data. So, and I know, Anita, we've shared cases of, you know, the HER2 or the hormone receptor positive, but is this grade 3? Like, do we call it invasive, you know, with the EPC type pattern, or is it, are they still sort of, you know, towards the typical EPC that we see? And I think those ones tend to be a little bit more challenging. But I don't use low grade EPC either, because EPC in my mind is a low grade lesion, so I stick with that. But I also put in a similar comment to what Anita does, to say that, you know, that there is data to suggest they are, you know, indolently invasive tumors, although the metastatic potential is low and should be in general staged and managed as in situ. So, you know, great case. And I guess now we have 2 HER2 positive ones. But yeah, another, I think, management challenge for these patients, because obviously the therapies for triple negative and HER2 positive disease is going to be quite aggressive.
I feel that when it's got an adverse biomarker profile, you feel, or certainly I feel more happy to put it in this category, for want of a better term. The case Anna Maria is referring to that I shared with her was grade 3, but it was ER and PR positive, and then you're getting, are you just overcalling this entity, and what are the implications for the patient? I think it's a little more nebulous.
Thank you very much. I think we should move on, and our next presenter is Dr. Jassim Radi from Lake Ridge Hospital. Jassim, are you there?
Yes, I can hear you. Okay, let me share my screen.
Okay, thank you.
Is it not?
Yeah, it's good. If you can just go to full screen mode. At the bottom right corner.
Let me get some help.
Jassim, you can maybe proceed with the case as it is. We can see your screen if somehow it's difficult.
How do you do this? Bigger, and then and then get into this sharing. How come it doesn't do it?
That's okay, Jassim. You can just proceed, and we can. I think we can see your screen better.
Can you see the presentation?
Yeah, we can see it.
Oh, okay. So I actually wanted to share with you an interesting case which we saw a year ago, maybe. And the most challenge is the biopsy is actually rather than anything else. This is a patient, 59 years old, presented with multiple heterogeneous masses in the breast. It's actually bilateral. And you can see the radiology, which showing multiple heterogeneous areas. And then we received biopsy of a couple of those lesions. And as you can see from the low power view, that this lesion is actually has some nodularity to it, and very, very cellular, as you can see. let's go a little bit higher power. There are areas like this where it's more of adenosis and some columnar cell change. And then you go areas like this in the same biopsy where you can see more of a solid nest with some sort of cells which has monotonous appearance and some small gland around with some fibrosis. And this is a higher power showing this these nest of cells which are some sort of look similar. They're medium to small in size, and they all have some sort of very similar appearance. And then in the same biopsy, there is an area which look more of like this, which is more darker cells and nest, and some maybe gland or acini in between, which some sort of appearance resemble some sort of adenoid cystic carcinoma, if you like, within the same lesion. So what to call this at that time was a little bit struggle. Is it really atypical ductal hyperplasia or ductal carcinoma in situ within adenosis? Or is it lobular carcinoma in situ? And some suggestion of could it be adenoid cystic carcinoma or salivary gland tumor? So yeah, now you rely on the immunohistochemistry, and this is ecadherin. Everything was staining positive for ecadherin, so it's not lobular, as you can see. And then when you do marker for myopithelial cells, actually highlighted nicely, there's a lot of myopithelial cells surrounding all of these nest of cells. And you can see from even this, the nodularity of the lesion. So this is rather unusual lesion. To give a definite diagnosis is a little bit difficult, but I thought at that time, this is atypical ductal hyperplasia, at least involving sclerosing adenosis, and with some comment about that area which looked like adenoid cystic, but it's actually with other immunos did not support the diagnosis of adenoid cystic carcinoma. There's, as you can see, there is no definite invasive malignancy. There's nice myopithelial lining, and we said excisional biopsy for proper assessment. So they did actually remove just lumpectomy part of the lesion, which is, you can see even from here how nodular it is, and also reaching the resection margin. And this is one of the areas which is sampled, and you can see how cellular this area and variable cellularity. Some are more cellular, some are nodulars, as you can see, have the appearance of sclerosing adenosis. And this is a higher power view where you can see some places has that much adenosis, and some solid areas and some areas which look very cribriforming, and a lot of this mixing of intermingling of these lesions. Another view, you can see the solid areas here, and then other cystic areas of, and then there is this cribriforming around them in there, which is a low grade. And this is the higher power view. You can see those cribriform areas, again with monotonous cells population, and those nodules of solid areas which are expanded by these cells, similar morphology. And there's a lot of sclerosis in the background. And actually at the edge here, you can see some features of sclerosing adenosis in there. This is the high power view of these monomorphous population of cells, and then some background of those which are really replacing most of those acini used to be there, and some cribriforming, and in some areas, and I think there's more of this. So again, some more of this, which is, you can see a background of adenosis, which is replaced by those cells. And this is another area which actually nicely showing it can be even mimic invasive carcinoma. But this is again area of nodular sclerosis involving by this ductal carcinoma in situ changes. There is a good area of nodular sclerosing, and then also some of those cells which look atypical involving this area. So when you do immunohistochemistry, it's really highlight nicely the ductal carcinoma in situ changes and a lot of this sclerosing area with this replacement by those cells. And also P63 can highlight most of those myophilia surrounding. And this is another area where you can see the DCIS and DCIS intermingle with those sclerosing area with adenosis. Then when we report the margin is negative, they went back and they did mastectomy, and in the mastectomy specimen, there was actually nice area of ductal carcinoma in situ, as you can see. So this case was also actually QA by UHN pathologist. So at the end, we call this ductal carcinoma involving adenosis, sclerosing adenosis. Thank you.
Thank you, Jassim. Very interesting case. And those sclerosing lesions are always difficult to evaluate, especially on the core biopsies.
Right.
Yeah. Any comments? Yeah. We have a comment that your pictures and photos are beautiful. They're really good. Does anybody want to comment on this case?
I would ask the presenter, so if you would order your myoepithelial markers and you would see that, let's say 1 or 2 or maybe 3 ducts or tubules actually did not show myoepithelial cells surrounding a very well-defined circular acinus, would you call it invasive carcinoma?
Well, we usually use more than one myopithelial marker, as you mentioned. And especially for this one, it's not convincing like invasive carcinoma.
Mm-hmm. Yeah, I agree with you that a panel is always good, but I think that in our practice, we saw some cases that when you stain for myoepithelium, there are just some acini that are morphologically indistinguishable from the rest of it that retain myoepithelial expression at the periphery, that where we don't see it. And we usually end up favoring that this is not representing true invasive component.
Thank you, I agree.
Thank you, Sharon. So now next case will be presented by Dr. Gulisa Turashvili from Mount Sinai. Gulisa, can you try to share your screen, please?
Yes, I'm trying to share the screen. Just a second. I'm sorry, just a second.
Take your time.
Can you see my screen? You should be able to see it now.
It's black, Louis.
No, it's still Jassim's screen.
I think I'm going to try again. Just a second.
Can you stop sharing your screen? Yeah, thank you.
Can you see it now?
We see a different screen.
This is Jassim's screen. Jassim, please
Stop sharing.
go to share screen and just say stop sharing.
I see someone else's screen. Maybe that's why my screen is not showing up.
Yeah.
You cannot start screen share while the other participant is sharing.
Jassim,
So the previous presenter needs to stop sharing. I'm sorry.
Yes.
Get out of it, that's sharing. I can't find that. It's supposed to be a square, come and you remove it. Where is it?
At the top bar, you will have view options.
How come it's
No, it's at the bottom actually, Sharon.
At the bottom? Oh, yeah, okay, sorry.
Share screen, you should stop sharing. Jassim, I cannot do it for you, unfortunately.
And then I'll go back again. Yeah. Can you do something to get up? Yeah.
Jassim, there is
we're trying to get up.
Yeah, there is a green share screen button at the bottom.
Okay,
yeah,
so it's fine. So Gulisa, now you should be able to, yeah.
Okay, I'm sure you can see my screen now.
Yes.
Okay, thank you. Good afternoon, everyone. I'll try to be quick. So this is a 62-year-old male who presented with a palpable mass. On imaging, it measured 4 centimeters on mammographically and 3.6 centimeters on ultrasound. The mass was biopsied and it was reported as spindle cell lesion with a wide differential diagnosis, including phylloides tumor and myofibroblastoma. I haven't seen the biopsy slides, but the excision was sent to us for consultation, and I would like to thank Dr. Varma for contributing this case. A gross examination showed a 4.1 centimeter well-circumscribed lesion in the excision specimen. And I'm trying to move to the next slide and it's not moving. Oh, okay. So this is a low power view of the lesion. I'm sorry, the faults are everywhere in this section, but I think it demonstrates the border of the tumor, and you can see how well circumscribed it is. There is fibroadipose tissue. There are no benign ducts and lobules within the lesion, and what we see is just intersecting fascicles of spindle cells. Here it's a medium magnification where again we see these spindled to ovoid cells. We have scattered blood vessels throughout, again intersecting fascicles of spindle cells. The nuclei are mildly atypical. There were occasional mitotic figures, approximately 2 mitosis per 10 high power fields. I think one of them is in the lower half of this picture, but no marked cytologic atypia. There is another field of view, and there was some description of possibly storiform, possibly even herringbone pattern of growth, but I think overall we can say that there are intersecting fascicles of spindle cells. This is just to show again the border of the tumor and how well circumscribed it is, and it has this thin rim of fibrous tissue. And this is probably the highest power picture that I have. Again, there is some cytologic atypia, but no marked atypia, and there are some mast cells scattered throughout the lesion. So of course, there was extensive immunohistochemistry done on the case. This shows smooth muscle actin, patchy expression. The next slide shows diffuse expression of ER, a strong diffuse expression, and PR showed the same results. Androgen receptor also showed some weak staining, patchy weak staining. And then there were other stains such as CD34, and the next slide will show other negative stains. I just decided to include CD34 to show that the blood vessels are staining, but the lesional spindle cells are negative. The negative stains also included desmin. I think this picture shows desmin, but other stains that were negative included S100 protein, SOX10, STAT6, P63, and low and high molecular weight cytokeratins, just to rule out metaplastic carcinoma. Obviously there was a wide differential diagnosis with metaplastic spindle cell carcinoma, other spindle cell lesions, mesenchymal lesions, solitary fibrous tumor, and so forth. And myofibroblastoma was obviously on the differential. However, as you can see, CD34 and Desmin are both negative. And then we did RB1, which is positive in internal control cells, which are blood vessels, but the lesional cells show loss of staining. So RB expression is lost in this case. So based on this morphology and immunoprofile, myofibroblastoma was favored. And I just want to briefly discuss the most common features of myofibroblastoma, and probably 98% of cases that we see will have one of those features. And then I just want to emphasize what are the unusual features that we can sometimes encounter in practice. So as you'll know, it's a benign tumor of fibroblasts and myofibroblasts. Usually excision is all you need to do in these patients. The incidence is the same in males and females, but most patients are either postmenopausal women or elderly men, such as in our patient, but the median age is considered to be 50 years. Imaging usually shows a well-circumscribed mass. Occasionally, it can be bilateral and or multicentric, but most cases will be unilateral. And it probably has hormonal etiology. And at least 80% of cases have 13q14 deletion, which results in RB1 protein loss by immunohistochemistry. And again, by gross examination, we have a well-circumscribed mass, as was in this case. You can have a variable ELO to white to gray cut surface. And most cases are usually around 3 centimeters, but they can be really large, up to 15 centimeters. So histology. So this picture shows probably the most common histology. Again, we have intersecting fascicles of spindles to ovoid cells, and quite often we have collagen bundles. In this case, we just had some focal bundles, and those were in the submitted slides. So I don't have a picture, but they were not well developed. Sometimes we can see focal storiform or schwannoma-like or neural-like growth. Usually there are no benign ducts or lobus throughout the lesion, and usually there is no significant cytologic atypia or mitotic activity. The cells have pale to eosinophilic cytoplasm. We can see mast cells and intranuclear inclusions in some cases. So what are the unusual features? We can have infiltrative margins, which are usually focal. We can have high cellularity, and arguably this case had somewhat increased cellularity. Sometimes we can see marked nuclear pleomorphism, but it shouldn't be diffuse, but focal pleomorphism is acceptable. We can see some multinucleated cells or hyaline globules or marked myxoid change, and even some osseous or chondroid metaplasia in some cases. So when you read the WHO, they list 5 different variants of mammary myofibroblastoma, including lipomatous, myxoid, fibrous, epithelioid, and palisading. However, there are some other variants such as leiomyomatous or cellular. They've been described as case reports in the breast, and they've also been described in the vulva. Arguably, again, this case could probably fall under the cellular myofibroblastoma category. Most cases are CD34 and Desmin positive. So over 80%, 80 to 90% will co-express CD34 and Desmin. Most cases will usually also express ER and PR. Those are usually diffuse and strong, as was in our case. AR can be positive, and the other possible positive markers include SMA, CD10, calponin, BCL2, and CD99, but those obviously are not specific for myofibroblastoma. Also, over 90% of cases have RB protein loss. And usually when we do stains such as epithelial stains, ALK, S100, STAT6, nuclear beta-catenin, they are all negative. So, I mean, there is a wider differential diagnosis, but I think in this case, I just included fibromatosis and fibromatosis like metaplastic spindle cell carcinoma, which can be excluded based on the immunohistochemistry. But in this case, there was another entity that we considered in the differential diagnosis, which was monophasic synovial sarcoma, because it was just so cellular and because it was negative for both desmin and CD34. But usually synovial sarcoma will have some expression of keratins, TLE1 will be positive, and then the characteristic gene fusion will confirm the diagnosis. So this case was unusual enough for us to do fusion testing, and it was negative. So it was just really not just the morphology, but diffuse ER expression and RB1 loss, and the negative fusion testing that really allowed us to make this diagnosis. And I'll just emphasize that CD34 deficient myofibroblastomas have been reported. The study that I included here has 6 cases, and lack of expression of both CD34 and desmin is highly unusual, but it's been reported in about 3% of cases. Just again, the reason to include this case today was just to emphasize that such cases exist. And if you rule out all the other more serious diagnoses that are on the differential, this diagnosis is a possibility. And if you have RB1 or you can send it out and it's lost, it definitely helps you be more confident in your diagnosis. However, if every second case of myofibroblastoma that you diagnose is CD34 and desmin negative, there is probably something that needs to be revisited. But again, negative CD34 and desmin in combination with RB1 loss can allow you to make the diagnosis of myofibroblastoma. And I'm not sure if anyone has seen such a case, or if you have any questions, I'll be happy to answer them. That's it.
I hope most people don't see that often myofibroblastoma to begin with, and then it's an unusual one. So Gulisa, maybe you just want to tell us what were the histologic features for this case that you started to think this is the diagnosis?
So again, intersecting fascicles of spindle cells, and of course you can see all those features in other spindle cell lesions, and it's really the immunohistochemistry that you want to use to rule out a metaplastic carcinoma, fibromatosis. And then again, in this case, it was highly unusual. It was a difficult diagnosis to make. And I would say that myofibroblastoma in a way was a diagnosis of exclusion until I got the RB1 IHC result. However, diffuse ER would have been unusual for metaplastic carcinoma, right? So it's just something didn't make sense. And it's really, you have to do all the stains. And then it was important to do fusion testing also to rule out synovial sarcoma, which can occasionally be ER positive. So again, a combination of IHC and molecular, and morphology was not incompatible with myofibroblastoma, but it was probably the last item on the list, because it wasn't enough to make a diagnosis. Just morphology is not enough. It's a combination.
Perfect. That's an amazing case. If we have any questions, please type them or raise your hand and we'll allow you to speak. Anyone has any comments?
Gulisa, I have one thing. It's Sharon. Thank you for a wonderful presentation. I wanted to ask you, do you think that you could have made this diagnosis at the time of core biopsy? I know it was not your case, but it's a hypothetical question. And do you actually need to nail this diagnosis at the time of core biopsy, or is it just enough to defer for excision?
It's an excellent question. I think if you think about myofibroblastoma in the biopsy, and the original pathologist did think about it and mentioned it in the diagnosis, I think RB1 IHC would have been helpful. I'm not sure that it was available to them. If you see diffuse ER and if you see RB loss, it's probably possible to favor the diagnosis, but I would definitely put a comment saying that lack of both CD34 and desmin is unusual And then I would just introduce some doubt, but I think it would have been possible to favor the diagnosis if RB1 had been done on the biopsy, possibly.
Yeah. Thank you.
Probably
Thank you.
just telling that it's not carcinoma is very important on the biopsy.
Right.
Yeah.
Yes.
Okay. So we have from Sonal, we have a comment. We actually did raise the diagnosis in the core, but I had some atypical features not fully in keeping, but so kept it as a differential. I think, of course.
Yes, thank you.
Thank you. Any more comments for this case? Okay, if there are no comments, that concludes our breast community of interest meeting today. The evaluations will be emailed to all participants within the next 2 days. And I kindly ask you, if you want to see those meetings coming, yes, please fill it out. We need to let the university know that we have a valuable community. Thank you, everybody, for great presentations. And thank you, Penny, for this excellent talk in the beginning. And we'll see you in a bit, in about 6 months, for the next breast community of interest. And thank you so much, Nicolina, Anna Marie Mulligan, and Sharon. Bye for now.